Welcome all. We continue with another important topic from the examination point of view is the tumor markers. Okay, so if you get a short note on the tumor marker, what are the things which you are going to write? You will write about the definition, what are the ideal characteristics of a tumor marker, what are the clinical uses, then you will talk about the limitations of the tumor marker, important tumor markers in the gynecological oncology you are going to mention, and some points from the practical points or the viva point also we will see. So what is the definition of tumor marker? Tumor marker is a substance selectively produced by the neoplastic tissue and released into the blood where it can be detected. So it is the substance selectively produced by the neoplastic tissue, okay, and released into the blood where it can be detected. And there are certain ideal characteristics of the tumor marker. So how should be the ideal tumor marker? First thing, it should be very specific and it should be secreted by the or produced by the tumor cells. Not all the tumor markers will fulfill all these criteria. But ideal tumor marker should have these criteria, like it should be produced by the tumor cells. It should be highly specific for a particular tumor. It should be highly sensitive. That is, it will detect the microscopic or subclinical disease. Then marker level should correlate with the tumor burden. High the tumor burden, there should be a high marker level. Okay, so useful for monitoring response to the treatment. Okay, so what is the response to the treatment? That also we should be able to uh, decide with the help of tumor marker. Then progressive rise indicates ineffective therapy or recurrence, inexpensive and easy to assay. So ideal tumor marker should be cheaper, okay, and it should have a easy assay. Then it should indicate presence as well as site of the tumor origin. Okay, so these are the ideal characteristics of the tumor marker. So what are the uses of the tumor markers? Screening, but it has got a very limited role because these tumor markers are produced when the tumor burden is increased. Okay, so for screening, we need to have the tumor marker in a very early phase, which is practically not seen. So screening has got a limited role, but diagnosis, yes, definitely. Then monitoring the response to the therapy. Next is the detection of recurrence. Follow up after the treatment, very important for tumor markers. Okay, role of tumor marker is there, and assessment of the disease progression or the regression. Okay, so what are the limitations? Most tumor markers become detectable only after the tumor burden reaches 10 raised to 10 cells. Okay, so this tumor marker will be detectable in the blood when you have the tumor burden which has already reached to 10 raised to 10 cells. Okay, so not sufficiently sensitive or specific for early diagnosis. So early diagnosis or sensitivity is not there because it will be produced little late. Okay, but it can be used for monitoring, not for the primary diagnosis. Okay, so what are the important tumor markers which we use routinely? Beta HCG, that is human chorionic gonadotropin. It is associated with the GTN, gestational trophoblastic neoplasia, then trophoblastic tumors, some germ cell tumors, dysgerminoma, embryonal carcinoma, etc. Then you have alpha fetoprotein. Okay, alpha fetoprotein is specific for endodermal sinus tumor or the yolk sac tumor. CA125, epithelial ovarian carcinoma or the endometrial adenocarcinoma. CA125 is the most commonly used for epithelial tumors. But does it satisfy the definition of tumor marker? Is it produced by the tumor cells? CA125? Is it produced by the epithelial ovarian cells? Find it out. Okay, then next is a CEA, carcinoembryonic antigen, ovarian carcinoma, that is serous, endometrioid, squamous cell carcinoma, etc. Then TAC72, that is the epithelial ovarian carcinoma. Macrophage colony stimulating factor is also for the epithelial ovarian carcinoma. So for epithelial ovarian carcinoma, you have CA125, TAC72, macrophage colony stimulating factor. Okay, then CA15-3, OVX1, OVX2, HER2. So these are for the epithelial ovarian carcinoma, out of which CA125 you have to remember. Beta HCG, alpha fetoprotein. These are very frequently asked, so you should write these things. Okay, commonly used you should mention. Then LDH is for dysgerminoma and squamous cell carcinoma antigen for squamous cell carcinoma of cervix, vulva, and vagina. Okay, then another important is a GAT. This galactosyl transferase associated tumor marker will differentiate ovarian cancer from endometriosis, because both levels, in both cases, CA125 level will be raised. Okay, endometriosis will also CA125 level will be raised, and epithelial ovarian cancer also CA125 level will be raised. Okay, then estrogen, progesterone, testosterone, they are raised in the gonadal stromal tumors, and inhibin is very specific for granulosa cell tumor. Okay, so the same thing is given in this particular chart. Okay, so germ cell tumors in which dysgerminoma, LDH is the tumor marker. Okay, so embryonal cell carcinoma, alpha fetoprotein, the most common is a SCG. Okay, and this alpha fetoprotein and LDH may or may not be. Ultimately, it is a germ cell tumor. So these are likely to have the LDH raised, but more specific for embryonal carcinoma will be SCG. Okay, then immature teratoma may have alpha fetoprotein, LDH, or DHEA. Then choriocarcinoma, HCG will be specific. Yolk sac tumor or endodermal sinus tumor will be alpha fetoproteins. Okay. Then sex called stromal tumors you have, in which you have thecoma, where inhibin is there. Then granulosa cell tumor, AMH is there. Inhibin is also there. Then sex called tumor, sex called tumor with annular tubules. Here there is no specific tumor marker. And Sertoli cell tumor, there are many like alpha fetoprotein, inhibin, testosterone, okay, DHEA, etc. Okay. So from the viva point of view, you should remember CA125 is the most important marker for epithelial ovarian carcinoma. It is invaluable for monitoring the disease progression and regression. Beta SCG is for diagnosis, treatment monitoring, and follow-up of gestational tropoplastic neoplasia. Alpha fetoprotein is a marker for yolk sac or endodermal sinus tumor. LDH is characteristic marker for dysgerminoma. Squamous cell carcinoma antigen for squamous cell carcinoma of cervix, vulva, and vagina. Inhibin specific for granulosa cell tumor. Okay. So same thing is given here. CA125 epithelial ovarian cancer, beta SCG GTN and tropoblastic tumor, alpha fetoprotein yolk sac tumor, LDH dysgerminoma, inhibin granulosa cell tumor, SCC antigen squamous cell carcinoma of vulva, vagina, cervix, CEA for ovarian, serous, endometrial, and cervical carcinoma, HE4 for epithelial ovarian carcinoma. Okay, so that finishes the topic of tumor markers. Thank you.